So I'm going to caveat my next question with a really serious caveat, but it's also a very serious question, and I was sort of on the fence about whether I'd ask you this or not, but I'm going to say screw it, and I'm going to ask you anyway. I'm going to caveat this by giving the disclaimer, which is you're a PhD scientist, you do basic research, you are not an MD, you are not an oncologist, and nothing you say is going to be construed as medical advice. So with that said, I still have to ask you a question, which is, if tomorrow you, your wife, someone you cared about deeply was diagnosed with cancer, and it was a cancer for which all standard therapies had been exhausted, and you are now left to the best insights you have with respect to your knowledge of cancer metabolism, tell me what pulling out all the stops looks like. And again, this is in the context of you've taken and you are complying with all chemotherapeutic, radiation therapy, hormonal therapy, surgical therapy, et cetera, but you're losing, right? So something else needs to be done. What does that combination of that something look like?
So I guess, when we think about the worst case scenario, we'd have pancreatic's pretty bad, but probably glioblastoma would top the list of things, right?
And would your answer be different if I was asking you about pancreatic adenocarcinoma versus GBM?
I think, it would be, there's things like with pancreatic cancer can make it hard for someone to follow the ketogenic diet, right? And liver cancer and things like that. So they need to approach it a little bit different. And you could have a lot of unexpected consequences, metabolic consequences by someone with liver cancer if they have heavy liver mets or
so let's make it simpler.
Brain cancers.
Let's talk about GBM and metastatic breast cancer. Okay. So start with GBM. Your loved one or you have GBM.
Yeah, I would say it would be useful, not necessarily, absolutely necessary, to ask for an FDG PET scan, do a PET CT, and especially, with GBM, it's going to light up like there's no tomorrow.
Right. So just for the listener, so FDG PET means you take glucose, you label glucose with a molecule,
radioactive label.
Yeah, and then when you do the PET scan, shows by lighting up anything that absorbs that, and the most rapidly metabolizing tissues of glucose light that up, which is almost always any cancer. And then a brain normally lights up, so a brain with cancer takes that to another level.
Yeah.
So you're doing that to document that this is a high glycolytic tumor.
Yeah.
Okay.
So even now, there's a lot of experimental things going on for GBM, but pretty much the standard of care is not offering any survival advantage when it comes to this. So we did...
GBM is uniformly fatal. I believe the 5-year survival is almost zero.
Yeah. Yep. And the mutation rate in GBM they're very, very heterogeneous in regards to the number of mutations. So many of the standard of care therapies that target specific pathways just are not efficacious because you have grossly mutated cells throughout the tumor. So my answer would default back to this press pulse idea that we published in Nutrition and Metabolism.
Is that the one in 2017?
No, actually, so the 2017 paper was in Seminars in Cancer, and that was with oncologists at the Moffitt Cancer Center, where we discuss how the ketogenic diet essentially targets the Warburg effect. And in doing so, really targets all the hallmarks of cancer. So any cancer biologist, is writing a review on paper, you talk about the hallmarks of cancer. There's enhanced proliferation, evasion of immune system, angiogenesis, all these different things, evasion of apoptosis. The ketogenic diet, nutritional ketosis, actually targets all those things, and even the aberrant metabolism and the increase in inflammation that is now a hallmark of cancer. So from the press pulse, the simplest way to describe it, at least its implementation, which I think is probably most important for the listeners, is to achieve a glucose ketone index. So press essentially means you're providing metabolic stress to the cancer cells that can stop their rapid growth and proliferation. It's like taking your foot off the gas pedal of cancer cell growth. And there's a number of things that we could do to slow down cancer growth and proliferation and metabolically stress those cancer cells. And that can be done continuously. And pulse protocols, you have a wide expanding toolbox of modalities that can be used in an intermittent fashion that can be sort of tactically used at different time points to kill off the cancer cells that you have applied the press stress to. So press protocols, which are done continuously, would be something like a calorie-restricted ketogenic diet, perhaps with intermittent fasting, perhaps a low-dose metformin.
And what was the ketone to glucose ratio that you want to see?
I would want to see anywhere between a maintenance of 1 to 2.
Meaning that's the glucose to ketone ratio.
A daily maintenance of 1 to 2. Yeah. So
glucose should never be more than twice the ketone level when both are measured in millimolar.
Yeah. Ideally, in a perfect scenario, 3 millimolar ketones, 3 millimolar glucose. So that's kind of hard to achieve, but not with a number of tools. So there's a number of tools that you can use to achieve that. And there are things that we could talk about too. So the fastest way to get to a glucose ketone index and maintain that of 1 to 2 would be what I would call supplemented ketogenic intermittent fasting, right? So when you eat within a restricted time window, say of like 6 hours a day, you start eating at 2 p.m. and finish at 8 p.m. Seems relatively easy to do. And within that fasting window, if needed, you could consume calories in the form of perhaps exogenous ketones, and that would further lower glucose and elevate ketone levels, like within a range. And there are commercially available ketone products on the market. Millions are being consumed, and there's no kind of adverse effects, when you compare it to something like a Red Bull, which you'll find lots of adverse effects. So there's fairly good safety data, but this needs to be studied.
The difference is Red Bull sponsors a Formula One team, so it's got to be
better. Yeah. So these things are relatively safe, and their utility are that, they can help you achieve a glucose ketone index. And when you do have a glucose ketone index of 1 to 2, you are limiting fermentable fuels to the cancer cells and also most likely suppressing the hormone insulin tremendously to get there.
And because I'm sure you'll be asked, or I'll be asked, is the reason you are applying an intermittent or time-restricted feeding algorithm to this because during the fasted time you increase ketogenesis, or because there was something specific about having complete liver and gut rest? In other words, is there a reason that an individual should or should not consume exogenous ketones and or MCT during the fasting window?
Yeah, I think if it's difficult for them to achieve a glucose ketone index of 1 to 2, one of the tools in the toolbox could be to consume exogenous ketones during that fasting period. I think it can be helped. And you can also consume them during the feeding period too. And they provide an extra source of calories that's a non-fermentable fuel, and I think have a benefit in and of itself. You could just talk about the anti-inflammatory benefits. I think there are a number of different benefits.
So that press protocol is pretty aggressive.
Yeah, and it could also include things like meditation and yoga. And exercise, of course, low intensity exercise, I think. But the most important thing from my perspective of the press, so we're just talking about the press, is to get that glucose ketone index to
2 to 1 or better, or 1 to 2 or better.
Yeah, 1 to 2 or better. And then once that is achieved, or concurrently, so you could think about different modalities for the pulse protocol. So changing your metabolic physiology with what we just described will have a huge effect on targeting the Warburg effect, and also will be already targeting all the hallmarks of cancer. So you have a different person. You have just changed that person's metabolism. The glucose ketone index of the average Joe out on the street is probably something like 25 or 50. It's like nowhere near that.
Right.
So you are literally changing the metabolic physiology of that person. So modalities that they may be resistant to or completely failed may have an effect now. So chemo, radiation, maybe immune-based therapies may be working now. But
that's an important point, right?
We view this as an adjuvant. So you could do a neoadjuvant, concurrent, or adjuvant approach. So, and I think that what I just described can be used as a neoadjuvant, concurrent, and an adjuvant approach.
Yeah, so people talk about cancer approaches as, look, you want to think about the legs of a stool. So you take a chemotherapeutic approach, you take a radiation approach, you take an immune-based approach, and you take a surgical approach. Those are really the 4 pillars of cancer treatment today.
Yeah.
You're basically saying, look, there needs to be a new type of oncologist, which is the metabolic oncologist. So you have a surgical oncologist,
Absolutely.
you have a radiation oncologist, you have a medical oncologist, you now have an immuno-oncologist. Why don't we have a metabolic oncologist?
Yeah, things will lead that way just by the research that's being done now, the huge amount of research being done, even on oncometabolites. And all the genetics people are now focusing on how metabolism is influencing genetics. Metabolism is a driver for our biology and influencing epigenetic expression. So, the work, I'd like to also point to the work of a friend of mine and colleague, Adrienne Scheck, who did her work at the Barrow Neurological Institute, which demonstrated in a mouse model, GL261, I think, model of glioblastoma, that using temozolomide and also radiation, with really focusing on radiation, that being in a state of nutritional ketosis made radiation therapy many, many times more efficacious. In that mouse model, which is kind of a gold standard model for GBM, it actually cured the GBM in that mouse model using the ketogenic diet combined with whole brain radiation. So that was a pretty significant finding that actually spearheaded some of the ketogenic diet clinical research that's being done now.
In her research, this was done with dietary or nutritional ketosis, not exogenous supplementation?
She went on to do some work with exogenous ketones and looking at how ketones can reprogram the metabolism, and ketones can actually have... they are like COX-2 inhibitors. They inhibit reactive oxygen species, which is driving growth and proliferation. So that work spawned research just on ketones by themselves in her animal model.
So what is in your PULSE protocol then?
PULSE protocol can be varied. So hyperbaric oxygen therapy.
At what frequency?
3, generally speaking. So with GBM, so a consequence of a GBM could be seizures, right? So getting hyperbaric oxygen therapy with a GBM is a bit tricky.
Careful.
So yes, you have to start very low, probably like somewhere around 1.5 ATA, and then work up gradually from there based on the individual person. But generally speaking, the research that we did showed that not 5 days a week, which is typically used for wound healing, but I do think there needs to be a day off for adaptive effects to happen. So 3 days a week, 2.5 atmospheres for 60 minutes, 3 times a week. And that produces, reverse tumor hypoxia for one thing. So hyperbaric oxygen increases tissue oxygenation, not by hyperoxygenating hemoglobin, but it actually gets oxygen into the plasma. And that's a very important thing because...
Meaning you solubilize oxygen within the plasma.
Yes.
Because you can't really supersaturate the hemoglobin that much more. You're at the top of the curve.
Yeah, you and I are sitting here, I don't know with this air here, but your hemoglobin is essentially saturated, probably 96, 98%. But the hyperoxygenation that occurs with hyperbaric oxygen therapy, and this is why oxygen therapy does not work independent of an increase in pressure, right? So the increase in pressure is needed to drive the oxygen into the plasma. And once it's in the plasma, tumors have erratic vasculature, right? And then the red blood cells get caught inside the capillaries and and the oxygen doesn't get into the tissue inside the tumor. But if the oxygen is in the plasma, it can get past and all into the nooks and crannies of the tumor, and then reverse tumor hypoxia, which is tumor hypoxia is driving HIF-1 alpha and VEGF and causing oncogenic activation.
So ironically, you're taking something that is initially a deficit of cancer, which is its hypoxia, but then it utilizes it as it's an advantage by saying, hey, I'm going to work around this. It's going to make me more resilient. It's going to allow me to increase my vasculature. Boom. And you're saying, hey, buddy, that little advantage you had that was a disadvantage, we're going to reverse it. We're going to hyperoxygenate you now. We're going to take away your hypoxia.
And
do you also increase free radicals?
Yes. So you have a dual effect, right? So you are silencing the oncogenes, you're turning off some of the oncogenes, and also by hyperoxygenating a tumor, which its baseline is to be in a state of hypoxia, by supersaturating the tumor with oxygen. And that tumor tissue has damaged mitochondria because hypoxia damages the mitochondria. So basically you're hyperoxygenating a whole bunch of damaged mitochondria. And essentially what that does is skyrockets superoxide anion, which then through Fenton chemistry, so when you have a lot of free iron and you got a whole bunch of heme and stuff that's being broken down the tumor. So you have a lot of free iron driving the Fenton reaction, and which is producing hydroxyl radicals, and that causes a massive oxidative stress specifically to the tumor. And you're delivering a massive oxidative stress to the tumor while it's relatively non-toxic to healthy cells that have normal metabolism, right? Because the tumor is thriving in a low oxygen environment, and you're reversing tumor hypoxia and hyperoxygenating it, and you have this environment which is just fueling redox stress, you can then trigger apoptosis and necrosis, really driving necrosis in these tumor cells. So hyperbaric oxygen delivered at the maximum tolerable dose 3 times per week. And you could further enhance the oxidative stress of the tumor by something that's, a lot of people haven't heard of this, but IV vitamin C. So vitamin C, if given intravenously,
you can give up to about 100 grams at that.
You could, 25 to 100 grams is kind of pushing it, but vitamin C, ascorbic acid, also functions as a glucose antagonist. So
yes, so you got to make sure you have dextrose on hand if patients.
Yeah, but not if you're in a state of ketosis, right? So if you're in a state of ketosis, so I did a pretty high dose vitamin C, but being in a state of ketosis, you can tolerate higher amounts, right?
Do you know what your glucose dropped to?
So when you measure your glucose, when you're getting vitamin C, you get a false positive on the meter.
Falsely high?
You get falsely high. Well, at least the Abbott Precision Extra.
Yes.
It's just, when you measure that meter, that assay on the meter is also sensitive to the pH of your blood too. And there's a redox shift, and ascorbic acid is a powerful reducing agent, and that might be altering the assay. So I was not able to get my glucose skyrocket. I know I went into it hypoglycemic, but my ketones were elevated, and I took a pretty big hit, of vitamin C. And I was just doing it just for the, the self-experimentation thing.
Right. So, but what's the thought here? So lots of people have talked about
stress. So vitamin C driving the Fenton reaction to produce more oxidative stress. So vitamin C is a pro-oxidant. When you get blood levels of vitamin C in the millimolar concentration, then it becomes a pro-oxidant. It's not an antioxidant. So we're not using antioxidants, or definitely you don't want to use antioxidants.
Yeah, I was going to come back to that. But the next thing is, I'm sure somebody listening to this is going to say, well, I don't have access to IV vitamin C if I wanted to do that.
You can't do it orally.
You can't do it orally because of what? It's not, you can't get it out of the gut enough.
You can't. You can only get a very small amounts. And then, your gut auto-regulates it too.
So let's get to the next thing you said, which is, again, highly counterintuitive to most people. We're hardwired to think that there's nothing better for you than antioxidants.
Yeah.
But paradoxically, once you have cancer, that might not be the case.
Yeah, so I think antioxidants may be blocking some of the efficacy of some of the therapies too, right? Because many chemotherapeutic drugs, their function works through enhancing oxidative stress. Radiation sure does. So radiation, maybe 20% of the cancer killing effects of radiation are due to damaging the DNA with double strand nicks, but 80% of the tumor killing effect of radiation is by the generation of reactive oxygen species.
Now, does that mean you can't have blueberries and things that have low levels of antioxidants?
I would say no, but you don't want to kind of saturate your body with a cocktail of antioxidants. Like, you don't want to do a glutathione push, right? After you do
same with NAC, so you wouldn't have NAC.
I personally would not. I don't think none of the cancer studies in animal models or humans are supportive of the use of antioxidants, and that was a big focus of me. I mean, during my PhD, I wanted to do a postdoc research in antioxidant cocktails that were going to save the world. And none of the research on antioxidants really panned out in my mind. There's a couple things, maybe for mitochondrial antioxidants for like Friedreich's ataxia and maybe ALS and some research there, but it's pretty subtle benefits. But in the context of cancer, no, I don't think antioxidants should be avoided.
Anything else in your PULSE protocol?
Yeah. I mean, there's a lot of things that you could add. So with the PRESS protocol, I think a low dose of metformin could be helpful too. So that will activate AMP kinase, maybe decrease insulin a little bit, maybe increase ketones a little bit too. And it's just a readily available, cheap drug that has a very good safety profile. 500 milligrams to 2,000 milligrams a day are usually well tolerated, probably starting with 500 milligrams and working up. But when it comes to the Pulse protocol, hyperbaric oxygen, IV vitamin C, and there are a number of drugs that we're working with now. One would be 2-deoxyglucose, which in and of itself, from a seizure world, and I've been a reviewer for the government for different grants and stuff, and this is in the context of epilepsy. 2DG is sort of like the ketogenic diet in a drug. So by inhibiting glycolysis, this gets back to the question, right? You have no ketones, but you inhibit glycolytic pathways, perhaps even like reduce sort of mTOR signaling or some glycolytic signal, and that may have anti-seizure effects. So 2DG is something that we're working with now. I think
what was 2DG originally developed for pharmacologically? It's been
It's
around for a
been
long
around for a long time. I think maybe it was just in the realm of experimental compound, but I know there's phase 2 trials in cancer. The problem is it becomes cardiotoxic above, say, 50 milligrams per kilogram. I know there's some evidence that cardiotoxicity, but at 25 milligrams per kilogram, at least on some of the grants that I reviewed, that had a pretty good safety profile for epilepsy. So, not making any recommendations out there, but I think 25 milligrams per kilogram seems to be within the realm of therapeutic efficacy and safety.
And this is being studied in humans, and they're out of phase 1. So you have phase 1 data to support that.
Epilepsy world. Yeah, and I think there's some cancer trials going on too. And I do think that synergizes really well once you create the environment where you put the PRESS protocol into action, then the cancer cells become even very selectively vulnerable to other things. Like 2DG will inhibit a glycolytic pathway that drives the pentose phosphate pathway, and that pentose phosphate pathway is responsible for enhancing the endogenous antioxidant capacity of cells. So it makes the cancer cells even more vulnerable to oxidative stress the more you can inhibit the glycolytic pathways. So 2DG, 2-dichloroacetate is something that we've worked with too. Inhibits PDH complex, and that can
Is DCA a drug that's been on the market for a long time?
It's a small molecule. It's been on the market for a very long time.
And what's its normal use?
Its normal use is lactic acidosis, actually. So one of the side effects of metformin, right, is once you start increasing the dose of metformin and escalating the dose, the problem that you run into, it's a very powerful activator of AMP kinase. Its effects are primarily through the liver, inhibiting gluconeogenesis, and it's a mitochondrial toxin. We published a paper that it increases ROS production from the complex 1 of the mitochondria.
So it's inhibiting complex 1, correct?
It's inhibiting, mildly inhibiting complex 1, and it's triggering what the cell experiences as an energetic crisis, and that, it has an activation of AMP kinase too. So you are creating a scenario where that's putting a lot of persistent metabolic stress on the tumor cells, and then you come in here with different modalities that have overlapping but independent mechanisms at producing oxidative stress. So hyperbaric oxygen, IV vitamin C, and then cancer-specific glycolytic inhibitors, 2-deoxyglucose, 3-bromopyruvate, and lonidamine. Lonidamine is also a hexokinase 2 inhibitor. And those 3 drugs that I mentioned right there, they are very powerful, and they need to probably be used in 2 weeks on, 2 weeks off strategy.
If somebody's listening to this and they're thinking, well, how the heck could I ever do this? Are there physicians out there who are obviously doing this under the full and legal umbrella of ethical medical practice? Is everything you're talking about purely theoretical, or are there ways to actually have these things implemented?
I think there are some physicians out there that are probably not making it public, but I think they are getting success with doing 25% of what I just talked about. They're not doing all these things, but everything that I just mentioned is readily available. I mean, you could, most of the compounds, even IV vitamin C, hyperbaric oxygen therapy can be costly if you don't have a hard shell chamber. But I like that with radiation, if you're giving radiation to your body, or it's like going in there with a flamethrower and you have a lot of collateral damage, whereas hyperbaric oxygen naturally elevates the precursor for oxygen-free radicals, and the cancer cells selectively produce more oxygen-free radicals. So it's a very gentle approach. And instead of thinking that we should just go in there and eradicate the tumor, I think it's more appropriate to give sort of a gentle stress to the tumor. So the therapy that I'm describing, if the patient goes into it, they're going to come out of it stronger than they were going into it. When you fat adapt and keto adapt your body, so many metabolic biomarkers start to go in the right direction. When you go in for chemotherapy and radiation and you measure things after, your body, you're a big inflammatory mess. I mean, you're metabolically deranged, you're insulin resistant, you are pushing things, and you have chemo brain on top of that may not be reversible. The suppression of your immune system with chemo is setting you up for more cancers, potentially other cancers. So the scenario that we envision is a comprehensive metabolic-based therapy where you go into it and it's a more gradual approach, and you start adding these modalities sort of as you go. You know, get the patient acclimated, you know, with that glucose ketone index of 1 to 2, and then start utilizing some of these other therapies. You could potentially put someone on an IV, right, and pulse a low dose of insulin to make them hypoglycemic, even 1 or 2 millimolar, and then deliver some of these agents where you've really restricted the fermentable fuels. So I'm a reviewer on different manuscripts that are coming in, and some of these academic and clinical oncologists are actually suggesting this in, you know, medical hypothesis papers now.
And that's kind of counterintuitive, because you'd think, well, the last thing you want to do for a tumor is give it insulin, because this is pulsatile.
And it's acute, and the amount of insulin, it's not like 20 IUs, it's something like 1 or 2 IUs. So the patient comes in fasted, and you give them just a little bit, and that's mostly facilitating glucose uptake in the skeletal muscle. So making it less available for the tumor, right? And that creates a scenario where you produce severe, what would typically be fatal hypoglycemia, and you could deliver ketones, you know, as an insurance, and also deliver some of these agents that you'd probably dramatically sensitize that tumor tissue to the other modalities. And I know, so, I mean, what I didn't talk about when I did the 7-day fast, like years ago, I brought my glucose levels down really low, and I got to a glucose ketone index of 1, or maybe even a little bit lower than 1.
So you were about, 3 to 4 on each of them?
Yeah, well, my ketones were about 4 or 5, and my glucose got down to 3. So that was the lowest I ever captured.
And that was just a 7-day fast?
Yeah, after 7-day fast, after a brisk walk at the end. So I never got ketones 7 or 8. I got it 4, after a long fast. But then I did, inspired by the Cahill study, I used various strategies to bring my glucose level down. Pharmacological strategies, and I did it slowly. And
just do me a favor, Dom.
Yeah.
I really would be kind of pissed off if you offed yourself doing dumb shit, because I think the world kind of needs you to stick around. So see if you can just maybe get an IRB to do this in the mice or something. There'd be nothing that would break my heart more than getting a call from your wife saying, Dom died of some freak hypoglycemic crazy accident. What's the longest fast you've ever done?